This presentation will cover other headache disorders. We've already talked about migraines, so this presentation will cover a few other common types of headaches. For each type of headache, we will talk about the prevalence, the pathophysiology, the clinical presentation, and then an overview of abortive and prophylactic treatments available. This presentation will cover tension-type headaches, cluster headaches, and medication overuse headaches. We will start with tension-type headaches. These are a very common type of headache. Approximately 80% of the population has experienced a tension-type headache in their lifetime. It is most common amongst individuals 20 to 50 years old. For those who experience these headaches, they are generally affected about 3 days of the month, and 60% of individuals experience an interference with their daily activities, such as work, because of these headaches. However, only 16% of individuals who experience these headaches consult their provider, which means that a lot of people are treating these headaches themselves with either OTC medications or other remedies. So pharmacists can play a huge role in management of these tension-type headaches. Even though tension-type headaches are very common, they are one of the least studied, and so there's little known about the pathophysiology of these headaches. It is thought that they are related to peripheral stimulation, which activates supraspinal pain perception structures. This can cause pain in the myofascial tissue, and this is the tissue that's surrounding and separates the muscle tissues located in the head and face. The central nervous system is thought to play a part in this pain process. Tension-type headaches do have a distinct clinical presentation. The onset is generally gradual. There's usually pain on both sides, so we call that bilateral pain. The pain is often located in the frontal or temporal region of the skull, and it is usually a mild to moderate pain. It is often described that it feels like a big rubber band is wrapped around the head, squeezing the head. This pain can last for minutes to hours. To contrast for migraines, it is very rare to experience nausea or vomiting with tension-type headaches, and it is also less likely that you will be sensitive to light and sound. But it's extremely rare that you would be sensitive to both light and sound with these tension-type headaches. There's also no aura associated with tension-type headaches. These tension-type headaches are often well controlled with over-the-counter analgesics such as Tylenol, ibuprofen, or combination products that contain caffeine such as Excedrin. These OTC agents are considered first-line therapy, and self-care is often effective in treatment. The caffeine in the combination products is thought to help increase the onset of action for the medications, and it also may increase the effectiveness of the Tylenol or NSAID combined in the product. Studies are mixed to whether Tylenol or NSAIDs are more effective for these type of headaches, so it's fine for patients to try either and to allow the patient to determine which one seems to work best for them. For more severe chronic tension-type headaches, a patient may use a prescription NSAID, which is stronger and a higher dose than the over-the-counter NSAIDs. Muscle relaxants are sometimes used, but there's mixed reviews on their efficacy for tension-type headaches. Patients are considered to have episodic tension-type headaches if they require abortive therapy less than 2 times per week. Similar to what we learned about with migraines, patients may need prophylactic therapy if they are experiencing this type of headache frequently. If they are requiring rescue medications more than 2 times per week or having more than 15 headaches per month, acute therapy is probably not sufficient, and they should be considering prophylactic medication. Like we said before, there hasn't been a ton of research on these headache types because they are generally mild and resolve with OTC agents, but some evidence has shown that antidepressants may be effective in treatment and may reduce the need for the OTC analgesics. Amitriptyline is the most studied, and it is considered first line. SSRIs may be a good option for patients who have comorbid depression or anxiety, and these agents in general have fewer adverse effects than the tricyclic antidepressants. A newer option is the use of Botox injections, which paralyze the muscles, which may be related to the tension-type headaches, but more studies are needed to determine the efficacy and appropriateness of Botox for these types of headaches. The next type of headache is cluster headaches, which are not very common at all, seen in less than 1% of the population. Different than most other headaches and migraines we've talked about, the cluster headache is actually more common in men than women, and only about 10% of patients who have cluster headaches will have chronic symptoms from these headaches. The pathophysiology is not completely understood, but it does share some similarities with migraines. It's believed that these cluster headaches are activated by the trigeminovascular neurons. It's thought that these neurons are activated by a dysfunction in the hypothalamus or serotonin regulation. The hypothalamus is responsible for release of hormones such as cortisol, prolactin, and growth hormone. During these cluster headache attacks, you can see changes in the levels of these hormones being released. Also during these attacks, you see the patients experiencing hypoxia or decreased levels of oxygen. This is quite unique to cluster headaches. Also during cluster headaches, you see inflammation in the cavernous sinus where the headache pain occurs. Again, cluster headaches have their own unique, distinct clinical presentation. The onset is usually very rapid and frequently occurs right after a patient falls asleep. Generally, it is one-sided of the head, often around the eye socket, also known as the orbital or supraorbital area. The pain is severe and penetrating and is often described as if an ice pick is being jabbed into the eye. The pain is very intense and very uncomfortable. The pain often inhibits routine activity when the patient is having one of these cluster headaches. The headache can be associated with rhinorrhea, tears, and eye redness. The patient may have several attacks multiple times a day for a few weeks and then go into remission of the attacks. This remission may last for years with no cluster headaches. It is rare that these headaches cause sensitivity to light or sound or are associated with nausea or vomiting. There's also no aura with these cluster headaches. Sometimes the pain from these cluster headaches can be so debilitating that it may lead to drinking or other substance abuse issues as patients try to control the pain. Management of these cluster headaches includes both abortive and prophylactic treatment. Abortive therapy is used to manage acute symptoms, and prophylactic therapy tries to help shorten the duration, frequency, and severity of attacks. Because the patients become hypoxic during the cluster headaches, giving oxygen can reduce the acute attacks, and oxygen is considered the gold standard. Other medications that have shown some efficacy include the dihydroergotamines and triptans, which are covered in the migraine presentations. Because the onset of these headaches is so rapid, we want to use medications that have fast onsets as well. So with the sumatriptan, we would be wanting to use the subcutaneous injection or the intranasal because those are faster. But with Zomig, the onset is fast with both the oral and the nasal administration, so either would be appropriate. Prophylactic medications for cluster headaches are similar to migraine and tension type. There aren't any medications developed specifically for this use, so we're using drugs from other classes of medications. Some of these we will cover in other presentations in this course. The most common is verapamil. About 70% of patients will find verapamil to be effective, but it takes about a week to start seeing benefit. Lithium is also shown to be effective and takes about a week to be effective, but lithium has a lot of hard side effects and drug interactions and warnings, so you really have to think about the patient's comorbid diseases very closely if you're going to start on lithium. Finally, for patients who do not get relief from either of those two, you may try prednisone, which is a steroid that helps reduce inflammation, but this is considered last line because the chronic use of steroids has a lot of side effects. So, cluster and tension type headaches are both considered primary headache disorders. The last headache disorder we are going to cover is a secondary headache disorder, and that is a medication overuse headache. These are also often called rebound headaches. The headaches are actually from the patients overusing the abortive medication too frequently over a long period of time. They are from the body becoming used to having the pain or headache medication on board on a regular basis, and then when it's stopped, it can cause this rebound headache. This is more common with the triptans and prescription medications, but it also can occur with OTC medications such as Tylenol or ibuprofen. It typically occurs with the patient who is using the abortive therapies more than 2 to 3 times per week. The presentation is generally a patient who has chronic headache symptoms, and with these headaches occurring more days than not over the past 3-month period. Generally, the patient will have little or no resolution with acute medications, and the headache may actually progressively get worse. The headaches may start out as periodic and transform into chronic headaches with worse symptoms. The patient may become unresponsive to prophylactic and symptomatic treatment. The best treatment for medication overuse headaches is to withdraw the medication that is being overused. This withdrawal or tapering off of the medication should be tailored to the individual patient and medication. There's no one best way to do it. Once the patient is off the medication, they should have a thorough workup to determine the underlying medical conditions or causes of the primary headaches. Oftentimes, patients who present with medication overuse headaches have a primary diagnosis that is not being well treated, or abortive medications are being used when really the patient should be on prophylactic medications. Also, it's very common to see patients with chronic headaches who also have underlying psychiatric illnesses, such as anxiety and depression. Patients should receive a thorough workup and treatment for those illnesses as well. Other therapies can also be used, such as stress management, biofeedback, acupuncture, and massage. Biofeedback is when you monitor your quantifiable physiological symptoms, such as your blood pressure or your heart rate. When you pay attention to those and you notice what those are when you're getting symptoms, then you can monitor these changes and help you become more aware of underlying triggers or precursors to headaches. The goals of therapy for the tension type and cluster headaches are the same as for migraines. We want to decrease the severity, frequency, and duration of the headaches. We also want to be thinking about safety for patients as far as limiting side effects and drug interactions. Plans should be tailored to individual patients. In summary, each type of headache disorder has a very distinct presentation and may feel different, but they have very similar goals of therapy, and some medications for management of headaches can be similar. Medications that are used to manage headache disorders often have many other common uses besides just for headaches. The overuse of abortive medications can have serious consequences, and patients should be monitored and educated properly on abortive medication use.